I'm Ginny-Tyler Meadows. I am a pharmacist here at UAB. I work in the clinic to assist with patients, specifically focusing more on oral therapies, but I'm here to help patients with whatever questions that they have about their treatment. We do have a specialty pharmacy here on campus. We help coordinate patients' medications. We also do benefits investigations for patients' medications. So what that means is we'll talk about it a little bit, but I file a lot of paperwork with insurance too. So I'm very familiar with that whole side of things, which can kind of be its own hiccup. But today we're going to talk about targeted therapies. I am sneaking a little bit of information in about more traditional therapies, but mainly just focusing on the targeted therapies and the good and the bad associated with them. There we go. Okay. I have nothing to disclose. So our objectives today are to identify treatment strategies for ECD, outline the good and the bad components of treatment, especially related to targeted treatments, review individual medications, discuss management strategies for more common potential side effects, and explain insurance and cost considerations. Very simply put, we have two main goals. So we want the medication to work, we want your disease to be stabilized, we want you to improve. But really, as a pharmacist, I really want you to be able to tolerate your medication. This presentation, I'm going to take the operation guy. So you may be familiar with this guy from the game Operation. Just really kind of pinpoint different areas that side effects can happen. So he's going to be along for the ride with us today. When medications are studied, we're obviously looking at how well the medication works. So that's the big part of research. We also do collect safety data when we're looking at medications. So we're looking at what side effects occur and what's more common and what is more serious, just so we can better anticipate what to expect for our patients. Gene mutations, as we've discussed already today, play a significant role in treatment because they can create a specific target. So we know that where the medication is going to work and how it's going to work a little bit better. Side effects are an unfortunate consequence of treatment. I do tell every single patient that I encounter side effects are a possibility, not a guarantee. I think we get really bogged down in potential side effects and anticipating how bad this medicine is going to make me feel. Now, this presentation, we're going to talk a lot about side effects. So I'm going to seem like a commercial on the television where it reads out every single side effect that's possible. But I do feel like it's also really important for you as a patient to be empowered to know what to expect, because I'm not doing you any service if I'm glossing over what could happen. So trying to find the balance between the good and the bad. ECD can be present in multiple locations in the body, which can influence treatment options. Medications can treat multiple locations of disease, so therefore it kind of makes sense that side effects could happen anywhere in the body. Here we have a scale of the good and the bad. So obviously, again, the good being treatment response, your disease is improving. Quality of life I have on both sides. So we've kind of touched on that already. Quality of life, we want your quality of life to improve and to be good. But, medications, side effects, the disease itself can also be on the bad side of things, that your quality of life can decrease. So we're trying to find the balance there. And obviously, side effects can be part of the bad and cost. So we all established, we've all know that treatment comes with good and bad. How do we anticipate the prospect of bad in the anticipation of good? You'll likely be on treatment. I know that we have some watching and waiting, some surveillance, but most likely you'll be on treatment at some point. So that might mean that you require different treatments for side effects or to prophylax, to prevent side effects. So it's maybe more than just one medication that you're going to take. So I'm going to ask you to kind of juvenile, but think about a deli sandwich, okay? So You know you're going to have your treatment. You're going to have your ham or your turkey on your sandwich. But the side effect treatments, the prophylaxis, the other things, maybe we're treating other symptoms of your disease. Those are the condiments. Those are, the other toppings to your sandwich. So just instead of thinking about it as all this negative stuff, let's think about it how it comes together to really, improve your life, improve your quality of life, improve your treatment. Here is a picture of the NCCN guidelines that we use. So it just has different way, like how we're considering treatment, where we're considering treatment. Most patients do require treatment. We may watch and wait. We may do surveillance. Therapeutic options have changed, as we've talked about earlier today. Most of these on the guidelines, most of the treatments are targeted. We do have the more traditional medications that you can use regardless of mutation. So we will touch on those. Like I said, I know that this presentation is primarily for targeted therapies, but I do think it's important just to review side effects of other therapies as well. Just to summarize what we've already gone over earlier today, patients undergo molecular testing. We're looking at mutations. We're finding targets. At least half of patients have the BRAF mutation, and here's that picture that Dr. Gold went over earlier of the pathway. So we know that these mutations are within the pathway, and hopefully we can target them to slow down or stop that cell growth. Other common mutations are from that MAPK, PI3K mutation pathways. We're targeting that treatment. And we kind of touched on this already, but there's no specific duration of treatment, so you could be on this medication for an indeterminate amount of time, prolonged amount of time, which is good in the sense of it responding to, your disease responding to it, but we want to make sure that we're constantly doing that scale, weighing the risks and the benefits of the medicine. So mostly we're using those BRAF medications, those inhibitors. We have the MEK inhibitors that we'll talk about. In other disease states, these medications are actually used together. Now in ECD, we're not really using it together. We're using them as single agents because the disease responds just as well to the single agent as it would with both agents. So that's when we're going in, we're weighing that, right? So it's not worth putting you at risk to be on two medicines to make you feel really crummy, as opposed to when you can just be on one medicine and it worked the same way. We may use, as we talked about, the MEK inhibitors if you don't have a specified BRAF mutation, or we're not sure, maybe we're waiting for that to come back. The MEK inhibitors can impact that pathway at a couple points, a couple of targets, so it is reasonable to start that medication before you know if you have that BRAF mutation. All right, so now I'm going to talk about specific medications. Again, just my little disclaimer that I'm going to sound like a medication commercial. We're really going to talk about the warnings and the potential side effects because, again, I think it's important for you to know what to expect and what to report. So first we have Zolbraf, that's the name brand. Giraffenip is the generic. It is the only medication that is approved by the FDA, and we'll kind of talk about why that's important a little bit later. The dose is 480 milligrams twice daily. It is approved up to 960, but patients have a hard time tolerating that medicine. We may even see that we decrease the dose even more. You can take it with or without food. We want you to avoid grapefruit when you're on this medicine. We'll talk about that as well. Now, this medication in trials and in practice is hard to tolerate. Obviously, you can see that here with the warnings and the side effects. So we're looking at your skin. So you're at risk for skin cancers, sunburns, rashes, your skin thickening, those types of things. Changes in your heart electricity. So we call that your QTC interval. We can look at that on an EKG, which if you'll look at the very bottom, we're going to do that. We're going to get one of those routinely. It can cause muscle pain, joint pain, hair loss, stomach upset, which includes nausea, vomiting. diarrhea, changes in your liver function, changes in your eyes, some swelling, some blood pressure changes. So this medication can really impact you all over your body. So if you were on this medicine, we'd want you to know anything new, different, concerning. Same with any. Tafenlar, Giraffenip is another BRAF inhibitor. It appears in some studies to be a little bit less toxic or better tolerated than Zolbraf. You do want to take this medication on an empty stomach. So I tell people on an empty stomach either an hour before you eat or at least 2 hours after. A lot of times I'll tell patients, get up a little early in the morning, take your medicine, and just wait till you eat breakfast. Again, you'll want to avoid grapefruit. Skin cancers can be possible. That same change in your heart electricity, eye changes. More common side effects including hair loss or alopecia, skin reactions, fever, fatigue, blood pressure changes, joint pain, headache, changes in your blood counts. Again, we'll want routine follow-up with the dermatologist, and we'll be getting an EKG for your heart. Cotellic or cobimetinib is a MEK inhibitor. Again, you can be on these medications even if you're waiting on your molecular assessment to come back. If we're not sure about your BRAF mutation status, you can be on this medication. This medication is, we do a 21 days out of a 28-day cycle, so that's 3 weeks on, 1 week off. So you will have a week off. You can take it with or without food. Again, want to avoid grapefruit. Promise we'll get to that. Some warnings can be changes in your heart, muscle. So that rhabdomyolysis is a fancy way of saying how your muscles are being broken down in your body. It can cause severe muscle pain, very limiting muscle pain. So you want to look out for that. Severe bleeding, new cancers, eye toxicity. And then eye toxicity with these MEK inhibitors is a really big concern. We will actually want you to see an optometrist. Go see an eye doctor, get your eyes checked while you're on these medicines routinely. Some more common side effects, changes in the way your heart's pumping, so decreased ejection fraction, high blood pressure, again, those skin reactions, sun sensitivity. This medication can cause an acneiform rash, so kind of thinking more like if you were breaking out. It's not like a rash that itches as much as you kind of feel like you're going through puberty again, right? So you're having that, you're having a more of an acne type reaction. Decreased electrolytes, stomach upset, nausea, vomiting, diarrhea, changes in your blood counts, changes in your liver function. Mechanism is our second MEK inhibitor. You actually have to take this medication on an empty stomach as well. The one thing about this medication that I always try to drill for patients is that it actually has to be stored in the refrigerator. So most of our medicines we can keep at room temperature, no worries. This medication you do actually want to keep it in the refrigerator. So sometimes that's kind of, it would be hard for me to kind of remember that because most of my oral medications I just keep, in my kitchen cupboard. So we've got that eye toxicity, new primary cancers, lung toxicity, major bleeding, heart toxicity, skin toxicity. Again, I know it seems a little overwhelming. We're looking for more common side effects, swelling, blood pressure changes, that acneiform rash again, abdominal pain, mouth sores, stomach upset. And as with the other MEK inhibitor, we do want you seeing your eye doctor regularly and also getting a dermatology checkout and also getting that EKG. So talking about the more traditional therapies, so this is Quadrupine. You can get it intravenously or subcutaneously. We do this in cycles, so you do 5 days every 4 weeks. Research for ECD has shown that most of the time we're not recommending more than 2 cycles of this medicine. There is some talk about maybe up to 4, but patients tolerate this better hanging around that 2 cycles. And I have here, it is infused over 2 hours. So, but you do need to have antibiotic and antiviral treatment to prevent, or because it will knock down your blood count. So we want to have those medications on board to prevent you from getting any kind of infection. And once your lab count stabilized, we're able to pull those anti-infection medications off. Pegasus is pegylated interferon. You may have seen regular interferon. That has actually recently been pulled from the market, so really we just have that PEG interferon available. It is a subcutaneous injection every week. You can administer it in your abdomen or your thigh. We want you to rotate injection sites, and we want you to administer it approximately the same time each week. So setting alarms in your phone, using calendars, those types of things can be important. There's some literature for the duration of Pegasus, and that's about around 2 years. There have been some case reports that showed response around that time frame. This is an option regardless of mutation status. Side effects are a little bit, interferon can cause a good number of side effects. The pegylated part of this medication is thought to improve the side effect profile as opposed to regular interferon. But we're looking at your blood counts decreasing, CNS depression, neuropsychiatric disorders, so we want to make sure if you notice any changes that we get, you evaluated for that. Dermatologic toxicity, eye toxicity, and then kind of seeing some of those same side effects: stomach upset, nausea, diarrhea, appetite loss, changes in your liver, insomnia, headache, anxiety, those types of things. So just couple more treatments we're going to go through, and then we'll talk about specific side effects. So sirolimus and prednisone. Sirolimus is an mTOR inhibitor. You can use this regardless of mutation status, although this mTOR inhibitor also does have impact in the PIK3CA with that PI3K pathway. We do dose sirolimus based off of your blood level, so it is kind of nice sometimes to be able to specifically target a blood level with the medicine so we know what your dose should be. And this is an option for refractory disease, so it's not something that we're going to start off with. It might take a few steps to get there, but it is a treatment option. Methotrexate is also a treatment option for ocular disease. It's used once a week. And then Kineret or anakinra is one of those medications typically used in rheumatology. It's an interleukin-1 receptor antagonist. It's a subcutaneous shot you give yourself daily. Most common side effect would be injection site reactions, but it is reserved for mainly less severe cases. I did include this. So these are medications that are being looked at for these specific mutations and targets. They're very rare, so these mutations would be very rare, but if you did have this mutation and other medications didn't work, we could get to the point where we were using one of these. I didn't go into each one of them because we'd be here all day, but I do want you to know that there are other options that we are looking at. All right, so this is kind of my bread and butter, the side effect management. What I like to talk to patients about, how I like to be a resource for patients. Just kind of talk about the most common side effects that I see and how to manage them. But again, I do want to tell you, side effects are a possibility, not a guarantee. And also, it's just really important to tell us what's going on. I know sometimes I feel like patients don't really want to bother their providers or tell their providers, but a lot of times we want to know, because if it's not related to the medicine, it could be related to the disease. So just knowing, want you to be empowered to report anything that you feel is new or different. So we do generally manage side effects the same, so it doesn't necessarily depend on your disease state. Sometimes there are disease states or medicine-specific management strategies, but generally speaking, we do manage side effects the same way. I will talk about non-pharmacologic and pharmacologic management for strategies. It is important to know that not everything requires another pill, because a lot of times people, patients will tell me they just want to stop taking as much medicine as they're taking. So sometimes there are options for those non-pharm interventions. If you do experience limiting side effects, we can do a couple of things. So it's important to know that just because you're having a side effect doesn't mean you have to come off the medicine, because I think sometimes patients they want to suffer in silence because they want to stay on their medicine. They don't want to stop their medicine because it's treating their disease. But know that we may have that option to dose decrease to find the balance between the good and the bad. And it is important, like I said, to report your side effects. So dermatology. So there's a lot of dermatology side effects with all of those targeted therapies. The one that I like to talk about first is that increased sun sensitivity. So I think we're a little desensitized to sun sensitivity, right? I think we think, oh, I don't really need sunscreen. I'm not worried about it. It is really important to wear sunscreen. It's really important to wear, layers or wear long sleeves, wear hats. I don't know where everybody's from, but I know if you live in Alabama, it's starting to get really just humid and very hot. So it's a little bit harder to wear, long sleeves everywhere you go. So wearing sun protection is just really important. And I have a lot of patients kind of laugh at me when I suggest this, but I do think it's really important to wear sun protection when you're in the car. You're sitting up against a window. I have plenty of friends that'll go on long trips and their arm will be sunburned by the time they get to where we're going because they didn't think to put on sunscreen. So even this mundane task, I would just, incorporate that into your daily regimen. Using moisturizers that don't have a lot of perfumes and dyes, that could be important too, because a lot of times if you're having some sort of skin reaction, even if it smells good, it might irritate that skin, might make a rash worse. If you do have a rash, we can talk about over-the-counter treatments like different topicals, antihistamines. There are different options we could use to treat a rash. Now, for the acneiform rash, we can prophylax you with antibiotic, so minocycline or doxycycline, or we can treat it. And then also there are some over-the-counter topicals that you can buy, like benzoyl peroxide. Sometimes different pharmacies have benzoyl peroxide actually behind the counter, which it can be interesting to go try just to walk up to, a pharmacy counter asking for face wash. But it is a really good option and it works really well. It can dry your skin out, so I do want you definitely moisturizing after using it. But it is a good treatment for that acneiform rash. Check your skin regularly. If anything new, again, let us know. Go to your dermatology appointments. I know when it comes to your ECD appointment, you're probably going to be really organized and go. I think sometimes with our supportive care appointments, we get a little lax, right? So you think, oh, I can't make it to the dermatologist today. I'll reschedule with them. And then 6 months, a year goes by and you haven't gone. So just making sure you're staying regular with those appointments. GI issues. So this, I kind of lumped all together: nausea, vomiting, diarrhea, abdominal pain, loss of appetite. Okay, so want you drinking lots of water. I know that's really hard for a lot of people, but now they have these really cool water bottles that have different times on it that you can just fill it up and take it with you each day and just drink. Yeah, I don't know if that is the type. I've had to do that because I was not a big water drinker, and now it's kind of trained me. But just however you can get the water in. So just thinking about staying well hydrated. You do not have to eat 3 large meals a day. I tell people graze, pack snacks. Just be prepared, because if you don't feel like eating, if you don't have an appetite or you're nauseous, the last thing you want to do is sit down to a really large meal. But if you like trail mix and you can keep trail mix on you or in your bag, maybe that'll help you get those calories in. That can help you. We want you eating. We want you feeling good. The brat diet is something that I recommend a lot. So that's bananas, rice, applesauce, toast. So eating those bland foods, getting you kind of through the nausea, through the upset stomach. Now, specifically for diarrhea, your first go-to is going to be Imodium over the counter. It's not going to interact with your medicine, so I'm not worried about you taking that. So, you can follow the package instructions. If that doesn't work, we can get you a prescription agent. Constipation is similar. There are some medications over the counter. Definitely recommend a stool softener like Colace. I think that's really good to incorporate into your regimen if you're experiencing constipation. But you can also use laxatives. Typically, we want you starting off with a gentle laxative like a Miralax or a Senna. Don't want you going straight to a stimulant like a Magox or something. Sorry, Mag citrate. And then there's multiple nausea and vomiting medications that we can give you as prophylaxis. So a lot of times patients want that on hand just in case, because it just feels nice to have that bottle tucked away just in case you start feeling really nauseous. And there are multiple options for nausea and vomiting that we can use for you based off of your tolerability. Joint pain, muscle pain. So we want you keeping a log of your muscle pain. Let us know the location, how long, if anything makes it better, if anything makes it worse. Now, the trick with that is we do want you staying active. So we want you to try to push through as much as you can, also allowing yourself to rest. So again, a different kind of scale, a different kind of balance between activity and rest. We could potentially use corticosteroids or various over-the-counter products to manage your joint pain. If that became super limiting, we can talk about dose decreasing, or even if we needed to get you a referral to another team to look at that and help us manage that, we can do that. Low blood count, so we're looking at that every time you're getting your labs done. Low hemoglobin is going to make you feel a little bit more tired, which is very unideal because there's not a lot to do for that fatigue. Low white blood cells, that puts you at increased risk for infection. So if you notice any infection symptoms like a fever, or even if a sore throat, runny nose, any kind of infection type symptoms, we would want you to let us know. And low platelets puts you at risk for bleeding. So any bleeding that you notice that lasts longer than 5 minutes, bruising that's unexplained or doesn't go away, gum bleeding, those types of things, we'd want you to let us know. So I'm just going to talk about fatigue and liver function on this slide together. So fatigue is my least favorite side effect of all the side effects, because a lot of times your disease might make you feel fatigued, your medicine might make you feel fatigued, and it's the one side effect that we really don't have anything to make you feel better for, and it just stinks. So again, I want you to set an intention each day to be active and an intention to rest. So schedule rests, allow yourself to rest, but don't over rest, because I think we're one of two people when we're fatigued. We're either the person who's just going to push through and keep going and keep going and keep going until you crash, or you're the person who doesn't want to get out of the bed and is just going to hang out in the bed, and that makes you feel even worse. So trying to find that balance, which can be really hard. And then your liver function, so we're watching that on your lab work, but if you notice any changes in your skin, the yellowing of your skin, yellowing of your eyes, or darkening of your urine, any kind of changes like that, we definitely would want to know. Additional treatment consideration, so a little bit beyond side effects. What is the deal with grapefruit? I get asked this a lot, because a lot of medications you may take, you're told you cannot have grapefruit, no grapefruit juice. It can actually increase the amount of medication in your blood. So the way the medicine's broken down, it can stop that and make you at higher risk for side effects. So I feel bad when patients really love grapefruit, but it is just best to kind of just eliminate that from your diet. Other counseling points that I really like to make sure patients kind of think about as you're starting therapies, not only for your treatment, but also for side effects or other comorbidities you may have. Missed doses. I know, especially when patients are on something like a chemotherapy agent or something treating a cancer, we're really serious about taking our medicines and not missing them, which is really great. But what I really do want you to also think about is, if you do miss a dose, I don't want you doubling up on the medication, okay? So sometimes people think, especially those twice-a-day medicines, sometimes people think, I missed my morning dose, I'm going to take it with my evening dose. That just puts you at risk for side effects. It's not going to make the medicine work any better. Because I think that's our mindset is, I need this dose because I need to have that amount of medicine in my body. And really, it's not going to work like that. It's just going to make you feel worse. So just don't double up. Take your dose as soon as you remember it, but As it gets closer to your next dose, just skip it. It'll be okay. Hand hygiene is really important. Obviously, we are still in the midst of COVID, and so I think we're a little bit more sensitive to hand hygiene now, but really I want you thinking about washing your hands after handling the medicine, because it will prevent exposure to other people around you from the medicine. Caregivers too, you handling the medicine, I want you washing your hands afterwards, because we want the medicine to work for the patient. We don't want other people exposed to the medicines, exposed to those toxicities. So just constantly washing your hands, keeping hand sanitizer next to, with your medicines, whatever works best for you to kind of remember to wash your hands after handling it. Pregnancy factors. So if a patient were to become pregnant on these medicines, we'd want to know. If they're planning pregnancies, we'd want to know. Some medicines, we actually do have considerations for male partners with, or male patients with female partners of childbearing age. So just having that conversation with your team, your healthcare team, can be really important, just so we can make the best plan. And then finally, drug interactions. So we're constantly running a drug interaction check. If you start any new medicines, it's really important to let us know so we can make sure that nothing's interacting, because we don't want you to be at increased risk for toxicity, but I also really don't want you to be at increased risk for the medicine not working. So it's really important to let us know when you start anything. And I will not get on this soapbox, but herbals are not studied regularly. So it is really important to have a conversation with your team about herbal supplements and what herbal supplements you're on, because we need to be able to make a plan if the medicine is not working as well, or if you're having side effects, because when medications are studied, we're not looking at herbal supplements. Herbal supplements too, they're not necessarily what you're buying in the bottle. There's no way to prove what you're buying in the bottle is actually in the bottle. So it's just important to have that conversation. I know that a lot of patients really like to be able to incorporate herbals into their regimen. We can talk through that for sure. I just want to kind of put that in the back of your mind. Insurance approval, yet another soapbox I could get on. Often with targeted therapies, we are going to have to do what's called a prior authorization with your insurance, making sure, that's us sending clinical information to your insurance company, proving to them that you need it, which seems kind of crazy, I know. Zolbraf is approved, so that does give us an advantage when we are talking to insurance companies. The other medications are off-label use, so sometimes it requires more than just that initial filing. Sometimes we have to do an appeal or two to get your insurance to approve it. So just know that sometimes that can take a little bit of time. And we do work really hard to get those approved. It is just something to consider. And it's really great that more data is being published, more research is happening, because the more research that comes out, the more evidence I have to submit to your insurance company to get them to approve it. Cost is probably my least favorite bad to medication, right? So I know I can anticipate side effects and I can help patients treat side effects, but a lot of times cost is something that I can't prevent, and it drives me crazy. So insurance copays can vary from plan to plan. So sometimes I think it's important to realize with cost is not just your medicines denied by your insurance. Sometimes your insurance will approve it, but you'll still have a very high copay. A lot of times, I don't know if you're like me, I'm not planning to spend, hundreds or thousands of dollars on medicine. So it can be a hard challenge to consider. So if you do encounter an unaffordable copay, we do have some options. So if you have commercial insurance, there might be a copay card from the manufacturer that we can apply to get your copay down. If that's not an option, there might be prescription assistance from the manufacturer. So we call that PAP. And we can file paperwork with them. It's a great option for patients with Medicare or Medicaid, and for patients that there's not a copay card available. However, sometimes there are different manufacturers that don't allow off-label use for their PAP program. So sometimes we might have to pivot depending on affordability of the medication, change treatment plans. So what we do here, at least at UAB, is we will engage our social work team. They're really experts in this. They help us file the paperwork. They help us get patients access to the medicine. So just know that your team may even grow by a couple more people. We do really utilize our social work team here. They're fabulous. There is another option. There's a grant from the Leukemia and Lymphoma Society. It's not always open, so grants kind of open and close. So what that means is sometimes they're enrolling patients and sometimes they are not. Depends on what funding they have available and how many patients they have signed up. Here at UAB, our team in the specialty pharmacy department, we are constantly looking for that grant to open up. So just know that that burden is not on you to look for. We are looking. We're trying to snag it as soon as it opens. So that is a really great option for patients that do have copays that are high. So how we know treatment works, we did talk about this earlier today. We're getting scans regularly. We're looking for that stabilization, that response of your disease. We do not know how long you'll be on these medicines right now, right? So it's just that risk versus benefit again. So we want you on it as long as you're responding and as long as you're tolerating it. If we have to dose decrease, if we have to take a pause, a holiday, we can do that. It just patient by patient. And then again, just increased quality of life. That's really the most important good. I want our patients feeling really good about where they are with treatment, where you are with side effect management, and just living the best life you can live. So that's really, it seems kind of silly, I guess, but it is really probably my main goal is just to make sure that you're feeling really great. So in summary, a lot of factors to consider when we're starting treatment. You have to, to anticipate the good, you have to prepare for the bad. So just knowing that you may have side effects, but that we have strategies to make those side effects more tolerable or go away. Again, thinking about the deli sandwich. So it's more than just, meat and bread. So there are a lot of different components that make your treatment unique and multi-layered. So just knowing that you have a team constantly evaluating what you need and how well you're being treated. And always utilize your healthcare team, including pharmacy. If you're somewhere that doesn't have a specific pharmacist in clinic, utilizing your local pharmacist, talking to them, they can help with side effect management. Just knowing that we're another resource. So you have a very large team, and pharmacy is very grateful to be a part of that team. It could be the side effect that you're experiencing, or it could be something worse. It could be a part of the disease. So it's just important to always talk to your team about it. Nothing's too small. We do want to know.